Alors, à l'ordre, bonjour.
Order. Good morning and welcome to the 17th meeting of the Standing Committee on Aboriginal and Northern Affairs.
On the unceded territory of the Algonquin Anishinaabe Nation. Aujourd'hui, on continue.
Today we are continuing our study on the administration and accessibility of the non-insured health benefits program for Aboriginal people.
We'll be hearing from the Honourable John Mayne, Minister of Health for the Government of Nunavut, the Honourable Julie Green, Minister of Health and Social Services for the Government of the Northwest Territories, and from the Honourable Tracy Ann McPhee, Minister of Health and Social Services for the Government of the Yukon. Je voudrais vous rappeler.
I'd like to remind you of the Board of Internal Economy's requirements regarding physical distance and the wearing of masks.
An orderly meeting, I'd like to outline just a few rules for our witnesses and members to follow. Members or witnesses may speak in the official language of their choice. Interpretation services in English, French, and Inuktitut are available for the first part of today's meeting. Please be patient with the interpretation. There may be a delay, especially since the Inuktitut has to be translated into English first before it can be translated into French and vice versa. The interpretation button is found at the bottom of your screen in either English or French or Inuktitut. If interpretation is lost, please inform me immediately. We'll have a pause and we'll fix the problem before we carry on. The raise hand feature at the bottom of the screen can be used at any time if you wish to speak or to alert the chair. Before speaking, please wait until I recognize you by name. If you are on the video conference, please click on the microphone icon to unmute yourself. When speaking, please speak slowly and clearly, and when you're not speaking, your mic should be on mute. A reminder that all comments should be addressed through the chair. So each organization, each witness will begin this proceeding by speaking for up to 5 minutes. We'll start with the Honourable John Mayne, Minister of Health, Government of Nunavut. Minister Mayne, you have 5 minutes.
Okay. Matnaugavit. I'm just going to speak in Inuktitut.
Thank you. Firstly, I want to thank you, your committee, for inviting us, myself.
All aspects of the non-insured health benefits program, also referred to as NIHB, have been coordinated by Government of Nunavut's Department of Health on behalf of Government of Canada. We achieved the coordination and delivery of this program through a series of contribution agreements negotiated between our governments. NIHB is essential to our territory in ensuring reasonable accessibility to non-insured health services and is considered a vital portfolio that often reaches the public spotlight here in Nunavut. This program, a few examples, provides the means by which a child in Arctic Bay can be escorted by their mother to a specialist appointment in Iqaluit without incurring costs for travel, accommodation, or expenses. It ensures that an elder in Qorlokto can obtain corrective lenses to see family on the horizon returning from a hunting trip, and that our residents who seek care in their neighboring jurisdictions are as comfortable as possible during vulnerable moments in their care and healing journey. The challenge of providing a wide range of care and services to a small population over a large, immense geographic landscape makes access to all required medical services difficult. While changes to the NIHB programs are at the discretion of the Government of Canada, Nunavummiut, employed by the Government of Nunavut, are directly involved in delivery of this program and in turn advocate on behalf of Nunavut Inuit to improve access to non-insured healthcare services. Currently, under the NIHB program, we're responsible for the delivery of medical transportation, accommodation and meals, dental services, and eye exams by an optometrist. Unfortunately, while the services I just listed have been successfully delivered to our residents, we have run into issues having them fully covered under NIHB, creating costs that our government has been perpetually required to assume. The territory has lost hundreds of millions
So, Madam Clerk, I see a freeze on Minister Main. Has everybody else noticed the same?
Yes, sir. We're going to address it right now. One moment, please. I'll confer with the MMS team. Unfortunately, Minister Main was dropped. We've got a tech on it.
Okay, so in the interest of time, do we have the other two witnesses with us at the moment?
Yes, I see Minister Green and I see Minister McPhee. I think both of them are with us. I see Minister Main is still with us if you want to pick up your remarks.
Okay, Minister Main, can you confirm that we can hear you at this point?
Yes, I can hear you. Apologies. It's Nunavut internet at its best.
No problem. You had about 2 minutes left. If you could resume your presentation, please.
Okay, thank you. The territory has lost hundreds of millions of dollars by covering costs not fully covered under NIHB. This is lost funding that we could have been funneling into improving healthcare programs, services, and infrastructure here in Nunavut. Over the last 4 years, our respective governments have been working together in negotiations towards a resolution. I'm pleased to advise that recently we have seen movement, and since 2020-2021 fiscal year, the Government of Canada agreed to an increase in the medical travel co-payment amount, a notional $20 million increase to the NIHB contribution agreement, as well as a supplemental $58 million contribution agreement intended to cover remaining incurred NIHB expenses, an interim measure to facilitate these discussions. And while we're still in negotiations, opportunities like this one here today allow us to listen, ask questions, and educate each other to ensure we're working together for a common cause. I'm just about done here, Mr. Chair. It's expected that a long-term agreement between the federal government and Nunavut will be reached before the end of 2022-2023 fiscal year, an achievement both parties can be proud of. And as we move towards this milestone, the Department of Health will continue to collaborate with the Government of Canada to ensure that services are accessible and provided to Nunavummiut. Another area of concern I'd like to briefly mention is the provision of dental services and optical exams. Like many jurisdictions across Canada, Nunavut is facing a backlog in these areas due to COVID-19 that is impacting our residents. Aside from this shorter-term challenge, there is a larger question around whether the amount of service days established for within NIHB are sufficient to meet the dental and optical needs of Nunavut residents in the longer term. Once again, Matna, I look forward to answering any questions. Apologies for the technical difficulties.
No problem. Thank you, Minister Main. We'll now go to Minister Green. If you're ready, Minister Green, you have 5 minutes. So, Madam Clerk, I cannot see Minister
Hello?
Green. Is she on?
Yes, sir, she was on mute.
Okay. All right. Well, I'll start the clock over. Let's get her going.
Okay, thank you very much, Mr. Chair. I'd like to thank you and the Committee on Indigenous and Northern Affairs for the opportunity to contribute to your study of the accessibility and administration of the non-insured health benefits program. I am on the line from Yellowknife, capital of the Northwest Territories and traditional home of the Yellowknife's Dene First Nation and the Métis. As Mr. Main explained, and is similar here, the GNWT administers portions of the NIHB program on behalf of the federal government with a service agreement worth $16 million a year. Our current agreement with the federal government expires March 31st next year. So the timing of your discussion is important. You have an opportunity to recommend changes that will strengthen the NIHB program. First, a little background on the NWT. We have a population of 44,000 residents living in 33 communities dispersed across 1 million square kilometers. A total of 44% of the population is eligible for NIHB benefits, and an additional 6% receive Métis health benefits. Métis health benefits are aligned with NIHB, but are paid for by the territorial government at a cost of $3 million a year. Because of the number of small communities and a lack of access to year-round roads, access to NIHB benefits, particularly medical travel, are critical to good health outcomes. The GNWT offers benefit programs pegged to the same level of coverage provided under the federal NIHB program to eligible residents, including the Métis and non-Indigenous populations. The GNWT recognizes the importance of providing a safety net to residents to reduce financial barriers to access health benefits not covered by the NWT healthcare plan. The GNWT's medical travel policy, for example, mirrors NIHB and offers the same benefits. The federal government has been an important partner in supporting the integrated service delivery model by providing funding to improve health services in areas of home care, mental health and addictions, system innovation, and most recently, of course, to assist in the response to COVID-19. Now I would like to explain some aspects of the GNWT role in federal NIHB program. The GNWT administers some parts of the NIHB program, as I said, on behalf of the federal government, including medical travel, dentist trips to communities, applications for medical supplies and equipment, arranging for the vision care team to visit communities where there are NIHB clients, and pharmaceutical coverage. Our role as an administrator puts us in a position where we implement the federal program and the public holds us responsible for it. In fact, we are the filling in the sandwich. This is not our program. However, in our role as administrator, we do receive feedback from NIHB clients on issues and concerns with the program that we share with the federal government for their awareness. Based on our experience in administering benefits, we know not all residents who self-identify as Indigenous have access to non-insured health benefits because their Indian Act status is in dispute. Medical travel, as I mentioned, is a very important part of the NIHB benefits program in the NWT, given how remote most communities are. It's also the area in which we receive the most complaints. The complaints address who is eligible for a non-medical escort and the timeliness of approval for medical travel and for escorts. The GNWT incurs additional costs, as Mr. Main outlined, associated with medical travel that are not recognized or remunerated by Canada. For example, 75% of the costs for non-medical escorts are for NIHB clients based on its service criteria, and which currently costs the GNWT $3 million a year. Just a couple of paragraphs to go. To support opportunities to provide feedback on NIHB program, GNWT works closely with ISC to facilitate trilateral engagement sessions with Indigenous governments, and we expect one of these sessions to be held later in the year. Our vision for the future of NIHB administration comes from the TRC calls to action, in particular Action 20, which states in part, we call upon the federal government to recognize, respect, and address the distinct health needs of the Métis, Inuit, and off-reserve Aboriginal peoples. One way to implement this action and advance reconciliation is to explore opportunities for greater direct involvement and leadership for NIHB in the NWT by Indigenous government organizations. We are happy to work in partnership with the federal government and the IGOs. I hope this information is helpful, and I would look forward to answering any questions you may have. Thank you.
Thank you very much, Minister Green. We'll now go to Minister McPhee. If you're ready, you have 5 minutes.
Minister McPhee, you're on mute.
You're unmute. You're showing as unmuted, but we can't hear you. Perhaps you could disconnect and reconnect very quickly.
I didn't do that. Okay, to start again. Sorry. Start my video.
Sorry, I didn't show you that. Yeah. No, I just turned
Sorry.
it off. You're unmuted. You should be able to hear it.
Can you hear me now, Minister?
Yes, we can. Please
Thank
go
you.
ahead. Well, I'll restart the clock.
Thank you so much. Apologize for the technical glitch. Thank you for the opportunity to be here this afternoon. I'm speaking to you from the traditional territory of the Kwanlin First Nation and the Ta'an Quechan Council. Thank you to my colleagues across the north for their important details about how the NIHB process operates in their territories. We have some similarities and some differences. In the Yukon context, we have 14 individual First Nations that operate here in the territory and we reside in their traditional territories. 11 of those First Nations are self-governing under the Umbrella Final Agreement from the early 1990s. That makes us a bit different and unique from other parts of Canada, of course. While I certainly agree with my colleagues about the benefits of the NIHB process, we are certainly not as coordinated an approach as, for instance, the Northwest Territories who administer the federal program. Our Canadian system of healthcare is, of course, complex, a patchwork of policies and legislation and relationships. We certainly submit to your committee for your consideration that a better coordinated approach is needed, but it does remain a challenge. In order to improve clarity and consistency of delivery, we are working hard here in the territory to improve our own system, and certainly changes to the way in which NIHB operates in conjunction with the Yukon system and how we provide service delivery to individual Yukoners, which of course is the primary goal, is critical. In a number of years ago, we are in the process of, we've had an independent review of Yukon's healthcare system known as Putting People First. One of the recommendations from Putting People First is, in fact, a better coordinated system with the NIHB. It indicates that certainly uncertainty in that process causes inequities. Provinces and territories, of course, have the responsibility to provide universal, publicly funded, insured health services to all residents of the Yukon Territory, including Inuit and Métis and First Nations individuals. But our Putting People First is an example, I think, of a health transformation project. We know that there are others that have happened across Canada, and it is aimed at improving health outcomes and access to services for all Yukoners, and focused in the process we are now focused on indicating how and determining how First Nations people can be a part of implementing the Putting People First recommendations from a transformational standpoint. We know that that will require organizational capacity and ultimate engagement with our Yukon First Nations and service delivery improvements, and not only from the Yukon health system, but from NIHB and how the two interact. We're focusing on new models of health service delivery. The current process that we have, without too much detail, involves, of course, NIHB being a payer of last resort, so determinations of whether or not individuals happen to be status First Nation individuals or otherwise, and whether or not the Yukon healthcare system, as a priority, looks after their costs. But the lack of coordination does create barriers to service consistency. As I've noted, our own insured health services need to be improved, and we are focusing on that. The Putting People First focus will be for people-centered, patient-centered, client-centered, trauma-informed wraparound services across the territory. This is particularly critical at this time, when better coordination will be our goal, especially as we face a substance use health emergency here in the territory. It was declared by our government on the 20th of January. We are seeking to provide harm reduction strategies that are new and improved. We certainly have individuals that, for instance, would qualify to have treatment outside of the territory for addictions that might be covered by Yukon government. They might be covered by NIHB. Those two things are not necessarily the same. The locations in which they might be able to go for treatment are not necessarily the same, and that certainly provides confusion. That whole process and the lack of coordination, I'll say, exasperates the experiences for individuals and adversely affects those Canadians that are often most in need. Our experience here in the territory is also that individual First Nations governments, of which we have 11, often end up absorbing costs for health services that are not theirs, and for which other governments are provided funding, whether they be the government of Yukon or otherwise. Want to focus just for a moment, I know my time is running out, but on wanted to come with a few solutions. I think language is incredibly important as we proceed to modernize our structures and make sure that they are meeting the needs of Canadians. I think we need to recognize that diverse governing structures do exist across Canada for First Nations, Inuit, and Métis people. Perhaps references to traditional territory or self-governing First Nations rather than just reserve on reserve, as a small example. But we do not have reserve land or individuals that live on reserve here in the territory. So unfortunately, just referring to the language sometimes confuses folks. We are very supportive of a trilateral table and a tripartite conversations, and I think Yukon's unique situation can contribute to some of those solutions, and we are very committed to doing that work with those at those tables, because we do think this is a system ripe for improvement, but we can do that together in partnership. There is an example of some rather successful reciprocal type agreements that exist, for instance, with the First Nations governments, Canadian provinces and territories around social assistance, for an example. So there is a framework.
Minister, I'm going to have to ask you to wrap up.
Yes, thank you so much. There is a framework that might be a guide for us, and appreciate the opportunity to chat today. Thank you.
Thank you, Minister McPhee. We'll start with the first round of questions. Mr. Shields, you have 6 minutes.
Thank you, Mr. Chair, and thank you to the honorable ministers who are presenting today. Very much appreciated. Minister Main, question in a sense, we've heard from the Minister of Northwest Territories the percent of the population that would qualify for NIHB. Do you have that number for Nunavut?
Thank you. It's roughly 85% Inuit. Nunavut's overwhelmingly Inuit. If I can get a more accurate number and get back to the committee in writing, if that would help.
No, that helps me lead to my next question. So in the decision-making process, if it was block funded, determining that block funding had the amount of it, do you believe you have the expertise to make the decisions for your residents that need to be made?
Thanks for the question. If it was block funded, there would have to be an escalating payment schedule, because what we're seeing here in Nunavut is year over year, the demand for services when it comes to medical travel, when it comes to mental health and addictions, our needs are just increasing quite steadily. And it's a reflection, I think, of the very young population that we have. So we're very young. If you look at the demographics, it's very wide at the bottom end of the age categories. And we also have some very serious social determinant of health issues that we're dealing with here in the territory, such as housing.
Minister, I understand that, and I understand, sorry to interrupt, limited time, but I understand, I know what the determinants of health are. So my question is, though, if with the funding, do you believe that you could make the appropriate decision to match those health standards?
I would have to take some time and ponder that. I apologize. I just can't give you an answer off the cuff in terms of that would be such a shift for this program to go to like a block funding, because right now it's based on the services, based on the quantity of, and those can vary from year to year. And as I mentioned, they are increasing. So I can't fully understand how a block funding model would work. It would be such a drastic change from the existing program.
Okay, thank you. This is how the provinces work, and it's one of the things that I would ask in that sense, is that's how the provinces deal with their health. So, Minister Green, to the Northwest Territories, number one recommendation you would have, if you could change it, as this committee could make a recommendation, what is your number one issue in the sense of that we could have as a recommendation that would make it work better for those health determinants for the NIHB clients in your territory?
Yeah, thank you for that question. It would certainly be helpful if medical travel was fully funded and that there was some consideration of the escort policy, whether it was a culturally safe escort policy. What we get a lot of complaints about is that people come from small communities. They are not accustomed to traveling to places even even the size of Yellowknife, which is a very small city, let alone to Edmonton and further south. And they would like people to accompany them, especially the elders would like people to accompany them. But this kind of compassionate accompaniment is not considered in the benefits of NIHB. They consider whether you need interpretation, mobility assistance, and so on, but not compassionate travel. So I'm concerned that what we're offering is not really culturally appropriate to the population, and I would like to see some discussion around that as a change. Thank you.
Thank you. Minister McPhee, I think you have moved into an area that I see happening even in my own writing when you're talking about language, for example. Could you explain a little more on, in the sense of recommendation that you started with that one?
Sure. Thank you for the question. I think it's incredibly important that the language be inclusive. So a lot of our interactions with the federal government, not only on this topic, involves us starting, although it's we've been at this for a while, so there's great understanding now throughout government that there are no reserves in the territory, that we do have First Nations governments that are governing their own traditional territories under the Umbrella Final Agreement. But there's no provision of any of those languages or inclusion of that kind of governance structure in policies or in directives that come out, maybe even in programming that comes out through a budgetary process, for instance. And as a result, First Nations governments and our government, all getting quite sophisticated, are saying, okay, where do I fit into this program? How does my governance structure, how will it benefit from this program? Will we qualify? These kinds of things. So, I mean, that was my point, is that we should be as inclusive as possible, and language is a good place to start.
Thank you, Mr. Shields. We'll now go to Mr. Pawlowski. Mr. Pawlowski, you have 6 minutes.
It seems like escorts not getting approved is a major problem. Who makes that determination as to whether or not someone is approved? And what are the reasons that are most commonly given for not approving someone? And now I think Ms. Green suggested, okay, if you need somebody as an interpreter, they'll get it approved, or if you need somebody because of your lack of mobility, they'll be approved. But if it's just because you're someone from Cambridge Bay who's never been outside of your community, if you speak a little bit of English, well, you're out of luck. Whereas if you don't speak any English, then you get someone to come with you. Is that the biggest reason for not approving escorts? And is there an appeal process? So I think this is kind of a major question. It seems like it affects all of you, and especially because as a doctor and having worked in at least in Nunavut, that I know that there aren't tertiary medical resources. There aren't a lot of specialists, if any, in those places, so they have to be referred out. So may I ask to all of you about the process? Why are people denied being escorts, and is there any effective appeal process? So maybe can we start maybe with Ms. Green, then Minister Green, and then you can pass it on to the other people.
Okay, thank you. Thank you for that question. So we mirror NIHB with our own ministerial policy on medical travel. The policy has 4 or 5 criteria, but none of them involve cultural safety or dislocation, compassion, or whatever. They strictly speak to areas such as mobility, interpretation, about to give birth, needing help to understand an aftercare plan, and so on. Our territorial policy has an appeal process. I'm not sure if the federal government has an appeal process for its administrative side of the program, but an appeal process is a good idea. So if there isn't one in place, it would be useful to have it, so that people who are denied an escort have someone else take a look at their file and see if it would be useful. That's my view on it. I'll ask John Main what he thinks. Thank you.
Mr. Main, I think you were...
Minister Main, do you care to comment?
Yes, thank you. When it comes to escorts, as I think Minister Green explained it quite well, I share the concern around the lack of, I guess, cultural sensitivity included under the program. We have had one of the issues that we have around escorts is from time to time a second escort is required. If it's, say, for example, at the end of the day, I like to talk about examples because this program is about people. It's not dollars and cents. It's about health care for Canadians who live in the North or who are Indigenous. So when you look at second escorts, we, in some cases, get requests from clients. If in the case of a child who's undergoing cancer chemotherapy, in some cases, the parent who is escorting that child needs support. And it can be very, very heart-wrenching. And, that's an example where that second escort, as a government of Nunavut, we could approve that and we will bear the cost on compassionate grounds. And just wrapping up my response, I'd like to mention that we have seen some improvements in this area through the Inuit Child First initiative, which is a new and kind of exciting avenue for Inuit in terms of second escorts and additional family travel around medical needs. Thank you.
Minister McPhee, do you care to comment?
Yes, thank you. I'll be very brief. The non-insured health benefits approves escorts in our context that are considered medically necessary, and that tends to be quite a narrow criteria. So I agree with my colleagues and certainly with the example given.
Mr. Chair, is time left?
You got about a minute.
Well, I guess then what you said, Minister McPhee, was kind of interesting because Minister Green said there were about 5 criteria, and you're saying it's whether it's medically necessary. Is there no common one requirement for escorts that kind of that applies all across Canada?
Yes, I understand that there's the basis of one. It's generally wrapped around this concept of medically necessary, and I think even that's what Minister Green is saying as well. There's a few criteria, but they're sort of in that basket, if I can say it that way. And of course, as the NWT administers the federal program through their system, they may well have incorporated some of those. I'll leave that to her.
Well, just probably less as a question, more of a comment. I thought, Minister McPhee, your comment about needing more than one escort when there's a child, especially in a life-threatening situation, I think was an excellent point. Thanks.
Thank you, Mr. Pawlowski.
We'll go now to Ms. Gill, and I understand that you're going to share your time with Mr. Morris. So together you have 6 minutes. Thank you, Mr. Chairman. I'd like to thank the ministers, Main, McPhee, and Green, for their appearance today before the committee. I have questions regarding the uninsured health care. There was the issue of a companion. Would you like to make any recommendations to the committee related with the fact that the territories are very remote? And certainly you have fewer health care services available. So if you want to make any to the committee. And of course, the question is for all 3 of the ministers.
With Minister Green, if you care to comment, then we'll go to Minister Main and then to Minister McPhee.
Thank you, Mr. Chair. Mr. Chair, I just want to clear up a little bit of confusion that I see between my answer and Minister McPhee's answer. The escorts I'm talking about are non-medical escorts. So they are not there to provide any kind of medical service. They are there to assist the person getting off and on the plane, speaking the language of their origin, and to accompany someone who's having a child, and so on and so forth. So they are non-medical escorts. We've had representation from people who would like the escort criteria to correspond with age. That is to say, if you're over a certain age, you would automatically receive an escort. It turns out now that the older you are, the more likely an escort will be approved, but that's not always the case. So having a wider availability based on age is one possible way to address the question of how do you bridge the gap between someone coming from a very small community to a city the size of Edmonton for medical services. It is truly bewildering in ways in which those of us who have been in those big cities.
Minister, I don't know if Mr. Main or Ms. McPhee would like to add anything, because I have little time. If they want to add anything to this, to potential recommendations.
So over to you, Minister Main.
Okay. Yeah, merci beaucoup.
Thank you very much for the question.
I think in terms of the escort piece, the flexibility, adding some flexibility within the policy would be valuable. It would allow the administrators or the territorial health departments to consider things such as cultural considerations, language considerations when we're looking at determining who gets a non-medical escort. And the other recommendation I would have would be around Inuit Child First initiative. Right now, it's new, it's very new, and I'm very appreciative of it. The Inuit Child First initiative and the non-insured health benefits they're kind of in silos, and they don't talk to each other very well or mesh very well together. So that's something that I believe could lead to improvements if we could figure a way specifically for Inuit to make those two streams work better together. Thank you.
Minister McPhee.
Thank you so much. I must say that I agree with the concept of flexibility. I think that's the umbrella with respect to how the policies are written and interpreted. That would allow us to take into account, for instance, compassionate reasons, cultural appropriate considerations, as well as language and what, of course, are medical concerns as well. But the flexibility is key.
Madame Gill, est-ce que vous allez...
Madame Ms. Gill? Yes, I'll give the rest of the time to Mr. Morris. Thank you.
Minutes.
Merci.
Thank you to Ms. Gill.
My first to Minister Green. I hope all parliamentarians in this place are committed to following through on the Truth and Reconciliation Commission's calls to action. Minister Green, you spoke about Call to Action 20 specifically. Do you have any additional recommendations for this committee with respect to NIHB to ensure we follow through on Call to Action 20?
Yeah, thank you for the question. I think that in order to advance reconciliation, it's important to take cultural safety into consideration. There's a lot of mistrust in the health system, even to this day, because of the way that it has been administered historically. So if there are ways to take that mistrust into account and to allay it by providing more flexibility, as Minister Main said, I think that would go a long way toward meeting this recommendation. Thank you.
Thank you, Minister Green. At the last meeting of this committee, Vice Chief Pratt from AFN shared that his words were, "For our First Nations, NIHB can be seen as a bureaucratic and intimidating entity. He went on to talk about concerns with respect to cost containment ahead of adequate and timely medical benefits. Would any of the ministers be open to sharing your views on recommendations that would address the concerns raised by Vice Chief Pratt?
So you'll have to direct that to one minister because we won't have the time.
How about Minister McPhee?
Thank you so much for the question. I do think it's what I spoke about in the concept of a coordinated approach. I think we need to be at a trilateral table. I think we need to really work at the details and the practicalities and of how the program operates on the ground, as opposed to in the concept of policy only. Like, what are the effects of that? I think we've heard some great examples today of what that could be, and a coordinated approach so that, and it would have to be individual to the territories, because I don't think we, the three of us, do things the same way across the top of the country. But I know that we are welcome partners to come and have those discussions and discuss how the NIHB program works and how it doesn't work, and how we can also make improvements in our systems.
Thank you, Mr. Morris. We'll now go to Ms. Idlout.
Thank you. First, I welcome you to this committee. Your presentation is very interesting. I welcome John Main, Minister of Nunavut Government in Health. It is good to see you. I will raise this question to all of you three in the order of your presentation. In your opinion, will paying Indigenous wellness counselors the same rate as the academically certified mental health professions have a positive impact of Indigenous people's health and well-being?
So, Minister Main, you could start off.
Yeah.
Yes, thank you. Regarding this, yes, I agree. It would be very beneficial to have the equal payment and acknowledge both traditional and academic. But the non-insured health benefits do not have that. They have policies which they need to improve, including traditional healers or counselors. Yes, it would be very beneficial for Inuit if our own counselors and professionals could be paid the same rate and recognized as such. Thank you.
Minister Green?
Yeah, thank you. It's very important that people see themselves reflected in the healthcare staff. It builds confidence in the system. And we've recently started a program here where we have hired Indigenous wellness counselors who were trained at Rhodes College in BC. And they are, we have made a community fund where communities can choose to hire them directly to provide counseling services in their communities. And we've had good uptake with that fund. People are very proud that that their community members have gone for this training and they're returning to provide this service in their community. And we would want them to be paid on par with non-Indigenous counselors so that the jobs are attractive to them. Thank you.
And Minister McPhee.
Thank you very much, and thank you for the question. I think the impact of culturally sensitive and culturally informed treatment cannot be overstated. I think the opportunity to have consistent or equality in wellness counselors' pay is absolutely the case. We know that healthcare is moving slowly, albeit moving, to the concept of patient-centered treatment and wraparound services, and we know that culture and language, but culture is such an important part of that, and clearly we need to make sure that all varieties of treatment are available and counseling are available, and that equality of pay is critical.
Thank you. I will ask this. What do you think? In what ways do those counselors, if you, I will ask you, do you think medical escorts provide a valuable service? But they also should not be volunteering only. They should be paid as well. What do you think?
So I'm going to assume that you'd like to hear from all three, Ms. Idlout. Okay, so we'll do it the same way. Minister Main first.
Yes. The escorts, we call them escorts in English. If they were to be paid a salary, it would be helpful because they leave their jobs and go on leave for a long length of time, sometimes without pay. And their family members, they have so many incidentals when they're escorting family members or patients. They are incurring personal costs constantly. Yes, their food is paid for, their accommodation is paid for, but there are incidental costs they incur themselves as well as the person that they're escorting. They become financially responsible for the patient. Not having a lot of access to money or having money is very common for many, many of us. I do believe that incidental costs that they incur for any length of time as escorts and for looking after their patients should be considered. Yes, I agree.
Thank you. Minister Green.
Yeah, thank you for the question. I recognize that time is valuable and people give it up to be medical escorts. My concern is about the cost because we mirror NIHB to our whole population, and we have about 18,000 medical travel trips a year, not all of them with escorts, maybe about a quarter of them with escorts. That would be a considerable extra expense for the government of the Northwest Territories. Even if the NIHB covered all of the NIHB clients. So our health system is in a deficit, and that deficit has been growing every year. So I'm concerned about that. While I recognize the value of offering payment to someone who's giving up their personal time, maybe an honorarium would be a more affordable way to do it. So this is a challenging question. I understand that it comes with a good intention, but I'm concerned with the cost. Thank you.
Thank you. And Minister McPhee.
Thank you again for the question. Certainly medical travel in the North is a way of life. We're doing more and more services locally all the time, but some, of course, just cannot be done. So it's an important question. I agree with Minister Green that ideally it would be something that could be done. An honorarium process could be more predictable as far as costs go, perhaps with averaging or understanding medical travel amounts, but we do have to recognize an aging population and the opportunity for those costs to increase. And again, I think as Minister Main said, this is about people. It's not about costs only, but we have to be mindful of that. So an assessment process or of some version would also probably be beneficial.
Thank you. Thank you, Ms. Sidlaut. I want to, unfortunately, we've run out of time. We have to follow this with another panel, but I want to thank you, ministers, Minister Main, Minister McPhee, and Minister Green, for giving your time today and answering our questions and making presentations. You've provided valuable input to our study. We very much appreciate it. Thank you very much. And with that, we will suspend for a few minutes to move to the next panel. Thank you. Today we will have with us Dr. Alika Lafontaine, President-elect of the Canadian Medical Association, Dr. James Makokis, appearing as an individual from the Plains Cree family. He's a Plains Cree family physician of the Kinoka-Ma-Sik Nehiyawak Nation, Treaty Number 6 territory, as well as Dr. Evan Adams, Vice President, Indigenous Physicians Association of Canada. Welcome to all three of you. The way we proceed will be that you will each have 5 minutes to speak, and after that we will go into a round of questions. We have an hour for all of this. So without further ado, Dr. Alika Lafontaine, if you are there, are you the one that's missing perhaps? Oh, no, you're there. I see you. Dr. Alika Lafontaine, please go ahead. You have 5 minutes.
Thank you very much, Mr. Chair. I'm pleased to join the committee from Treaty 8 territory today, the traditional and present-day territory of the Woodlands Cree, Dene, and Métis Nations. I am Dr. Alika Lafontaine, a Métis anesthesiologist of mixed Indigenous ancestry working in Grand Prairie, Alberta. It's my pleasure to appear before you as President-elect of the Canadian Medical Association and commend the Standing Committee on Indigenous and Northern Affairs for undertaking this study and inviting the Canadian Medical Association to be a witness. Improving the administration and accessibility of the non-insured health benefits program is a key part of addressing the health inequities between Indigenous and non-Indigenous people in Canada. The Canadian Medical Association is committed to promoting equitable access to timely, quality care in all Canadian health systems and strongly supports Indigenous health transformation towards these goals. The CMA recognizes that the most important voices in this evaluation are those who are directly impacted, First Nations and Inuit patients who access these services directly. We hope that communities, families, and patients who utilize the NIHP program are fully engaged and heard throughout this study. I hope to enhance this discussion by sharing two perspectives. The first is the lived experience of non-Indigenous physicians who support patients eligible for NIHP programs. The second is my own personal experience as a specialist physician in a regional center servicing Canada's North. Unlike my primary care colleagues, I do not interact with NIHP directly, but I do support patients who depend on NIHP programs like medical travel to safely transport to and from our regional hospital. It is important to acknowledge that without NIHP, many patients would be without any meaningful access to certain types of care, including surgical access and in-person specialist consultation. Canadian physicians agree that NIHP needs modernization. Modernization should reduce fragmentation in the patient experience and provide efficient and clear decision-making pathways for physicians and NIHP administrators to make patient care decisions. Healthcare systems should be focused on getting patients to the right care at the right time in a patient-centered way. The CMA has long advocated for reducing healthcare fragmentation through modernization. Our recent call for federal leadership on pan-Canadian integrated health human resource planning is a case in point. Similarly, we support the increase in consistent integration of resources within the NIHP program to promote better coordinated care for patients and more effective engagement of health providers, supporting and advocating on behalf of patients navigating these programs. Fragmentation can be considered in different categories, and I will address two. The first category is overly complicated workflows where roles are poorly understood. There is a considerable amount of time and energy that physicians, patients, their families, and NIHP administrators use in navigating paperwork and decision-making structures. Unlike provincial and territorial Medicare, where physicians can provide direct approval and access to services, the added administrative layers of NIHP create opacity on the physician's role and jurisdiction in these processes. The CMA's president, Dr. Catherine Smart, is a pediatrician in the Yukon. Dr. Smart's experience of teaching herself how to utilize and navigate NIHP on behalf of her patients and families is a shared experience of many physicians across Canada. The second category is a lack of integrating modern technology towards patient-centered, patient-engaged efficiency. Navigating paperwork and people can take up hours of their physician's time, filling out paperwork and looking to connect with people over the phone. These paper forms must then be faxed through an asynchronous communication system that dooms too many of these requests to disjointed dead ends. The physician is often the last to learn that the loop was never closed, delaying care and often resulting in worsening patient outcomes. NIHP has yet to be tightly integrated with mature, centralized patient experience and quality improvement departments, so these situations are likely not tracked or addressed in a broadly consistent way. Secure digital communication where patients engage with providers on their own journey from beginning to end now exists in many health systems across Canada. In place of a series of non-contiguous faxed forms, secure digital communication can close that loop, informing, tracking progress, answering questions regarding a medically necessary request that is processed through NIHB. It also provides a digital audit trail that could improve patient experiences and iterative quality improvement. Colonization, systemic racism, and lack of investment in healthcare infrastructure add additional layers of complexity to the modernization of NIHB.
Stand by, Dr.
Mr. Chairman?
Oui, Madame Gill.
Yes. The interpretation just took up. The sound was bad and they had to stop the service. Thank you.
You okay now? Vous êtes correct là?
D'accord, monsieur.
Are you all right now?
Que
the interpreter was saying that the witness doesn't have the appropriate headset, that perhaps that's one of the reasons why. So if we could have a copy of the speech, that would be helpful.
Apparently you don't have the normal headset that we use for our interpreters, but I would ask you to conclude, but speak a little bit more slowly.
Sure, sorry about that. Just in conclusion, the CMA recommends that this initiative be coupled with sustained investments to address the ongoing structural inequities that marginalize Indigenous peoples, advance the inclusion of Indigenous peoples in societal systems and sectors, and commit to collaborative and respectful relationships with Indigenous patients and communities. Thank you, Chair.
Thank you, Dr. Lafontaine. We'll now go to Dr. James Makokis. Doctor, you have 5 minutes.
Kansen temte ke guanawaga makante, utenionic scoponic, natanskutapana, kamasanama, kumanikotoasikasu. I'm from the Saddle Cree Nation and a descendant of signatories of Treaty Number 6. I'm one of the few Indigenous physicians who grew up with my people and who works with my own people. Presently, I work on Ginokamasik. I am testifying as a user of the current NIHB program and as a Nehio physician who treats Nehiyawak on a daily basis, also users of the NIHB program. I greet you today in the language of my people, Nehiyawewen, that comes from these lands upon which your people now sit, welcomed by my ancestors nearly 500 years ago, a language imbued with sacred teachings of natural law, which governs our people with laws that roughly translate to kindness, love, honesty, sharing, respect, family, trust, reciprocity, fairness, equity, care, longevity, and above all, honor for our mother, the earth, and all of its inhabitants. The same language was used to agree to a treaty that allowed for your ancestors to respectfully share these lands in exchange for peace and friendship, mutual understanding, and the promise of health and healthcare, also known as the Medicine Chest Clause, to be honored for as long as the sun shines, the grass grows, the rivers flow, and as long as there are native peoples. In English legalese, this would be represented by the phrase, in perpetuity throughout the universe. If the promise of treaty had been truly honored, I'd speak to you in my own language, and all of you would fully understand what I'm saying. We'd sit around a fire, begin our conversation and ceremony with a prayer and the guidance of a pipe, the keeper of our laws. And we would sit in to discuss these matters until the matter at hand is resolved. Yet I sit here and speak to you in English, a foreign language, with much too short of a time limit to articulate the shortcomings of a program that shouldn't even be an issue because everything I'm going to discuss was already promised to us over 150 years ago when your ancestors agreed to treaty. To discuss these matters as an Indigenous physician is insulting because not only is our health and healthcare guaranteed by our treaty, which continues to be in full force and effect, but the Government of Canada ushered in the era of truth and reconciliation in an attempt to correct the reality of what is actually happening to our people, which is genocide. Yet I still have to sit here and point out the ways in which NIHB continues to not only fail to provide adequate health measures for our people in the most basic ways, like giving the necessary number of catheters to patients without having NIHB bureaucrats instruct these same patients to wash and reuse their catheters, which goes against medical standards, but also to do so in communities with boil water advisories, as was the case when I practiced in my own nation in Saddle Lake in 2013. We wonder why Indigenous peoples have high rates of kidney disease and dialysis. Or the 17-year-old Cree person from my community who suffered a spinal cord injury, and when the ISK nurses asked me to assess her, had a stage 4 sacral ulcer. For those of you who don't know what that means, the ulcer was so deep I could press on her tailbone. Why did she have this? Because NIHB would only provide her with a new wheelchair at limited intervals. But children grow, and she outgrew her wheelchair, causing these pressure ulcers. Jordan's principle was passed in an effort to address these issues, but they still persist. This February, it took 2 months to get an appropriate nutrition formula for a 4-month-old Cree baby at a time in their life when their brain is developing the most. And we wonder why Indigenous youth do not graduate high school. To get anything covered through NIHB requires extensive and exhaustive advocacy. I once required post-exposure prophylaxis, antiretroviral HIV drugs, after I performed a procedure in my clinic. The ID specialist recommended I take 2 drugs within 72 hours of the incident. NIHB denied the claim. I then had to get on the phone myself and speak with the NIHB bureaucrat, who then directed me to the national pharmacist of NIHB program. I had to tell the national NIHB pharmacist, if you do not give me these anti-HIV medications, I will be at Canada Place on Monday morning with the Grand Chief of the Confederacy of Treaty 6 stating that your policies have possibly caused one of the few Indigenous physicians in this country to contract HIV, and it will be in the media. Is that what you want? Only then was this medication provided. How would the regular person be expected to know how to navigate and advocate through this bureaucratic mess? And we wonder why Indigenous peoples have the highest rates of HIV infections. On April 25th, our home care nurse stated that NIHB would not cover wound supplies for a 65-year-old Cree woman who was palliative dying at home with metastatic cancer. She required daily dressing changes, and NIHB would only give 1 dressing every 3 days. I had to spend 60 minutes on the phone with the NIHB bureaucrats and speak with a supervisor explaining that if the patient died of sepsis, I would put how their actions contributed to her untimely death. It is only when physicians make drastic statements that supplies, equipment, and medication is covered. We should not have to do this. Family physicians, specialists, and allied health professionals repeatedly state how difficult it is to work within this program, to have the appropriate coverage obtained for Indigenous peoples, and how can this be improved. I recommend that the NIHB program be evaluated by Indigenous scholars, allies, and users of the program, and then changed to create an inclusive, responsive, and comprehensive program that actually meets the real health needs of Indigenous peoples. The current NIHB system only further contributes to our early morbidity, mortality, and its use is a risk factor for our early death. Hi.
Mr. Chair, you're muted.
Thank you, Dr. Makokis. We're now ready for Dr. Evans. If you're ready, you have 5 minutes.
Great, thank you very much. And my apologies for arriving late. We were having some difficulty. Signing on. So I am here as a dual representative, as the Deputy Chief Medical Officer at First Nations and Inuit Health Branch headquarters in Ottawa, but also as the Vice President of the Indigenous Physicians Association of Canada. The Indigenous Physicians Association of Canada is invested in supporting Indigenous physicians across the country, Indigenous patients and clients, Indigenous health, and transforming the system. And we understand that the colonial experience or the health interrupted of Indigenous peoples are major factors in their unwellness. And we advocate for self-determination and governance or Indigenous control over Indigenous health services, recognizing that health services, access to health services, and health services as a determinant of health is in a spectrum of the social determinants of Indigenous health, which I'm sure you have heard about quite often here. A few items that the Indigenous Physicians Association of Canada would like to touch upon, which is the need for good distinctions-based First Nations, Inuit, and Métis public health data, or really just health data, so that we get a clearer picture of where we're working, how our clients are doing, that will point us in a direction of wellness. There are a few areas that, there are many areas where Indigenous peoples need help and support, but here are a few. Communicable diseases, mental health and wellness have been identified quite early on as a need. particularly by the chiefs of Canada. Other social determinants of health, like housing, and of course the area where we work, which is in communities or within the territories of First Nations Inuit Métis, and within our clinics and hospitals. So you've probably heard by now a number of aspects of the non-insured health benefits program, but I wanted to touch upon a few areas where we often complain or hear complaints, which is the NIHB program appeals process. Coverage for a benefit through non-insured health benefits program is denied. Clients, parents, legal guardians, or a representative of a client may appeal the decisions. There are 3 levels of appeal available. Appeals are assessed by a different program official at each appeal level. The NIHB program aims to send clients a written explanation of the decision for an appeal within 30 business days, 80% of the time under normal circumstances after receiving completed appeal documents. The First Nations Health Authority of BC understood that the timeliness of the appeals program was difficult and endeavored to do quality improvement so that that period of time for response and for appeals was considerably shortened. Medical transportation to access traditional healers. Non-insured health benefits also supports access to traditional healing services through the medical transportation benefit, which provides eligible clients with coverage for transportation to access health services not available locally, including traditional healing services. As far as catheters, which were a topic of discussion a couple of years ago, but bears reiteration, items covered under NIHB program's medical supplies and equipment benefit are intended to address our clients' medical needs in relation to basic activities of daily living, such as eating, bathing, dressing, toileting, and transferring. In 2017, NIHB increased coverage for disposable intermittent urinary catheters to 4 per day and removed the prior approval requirement. Non-insured health benefits reviews its services and coverage regularly. We have a non-insured health benefits oral health advisory committee, which is made up of several dentists, and their bios are available on our website. A drugs and therapeutics advisory committee, which includes 7 physicians and a few lay people, which is chaired by Dr. Derek Jorgensen and vice chaired by Dr. Marlon Cook, an Indigenous physician from Manitoba. And we have a medical supplies and equipment advisory committee, which includes vision care experts, a registered nurse, family physician, a public health physician, health economist, an ophthalmologist, a podiatrist, et cetera, et cetera. So we, and just as a side note, absolutely I understand that quality control and quality improvement of Indigenous, services for First Nations, Inuit, and Métis are an important aspect of system transformation. And we take that transformation seriously, and we understand that consultation with health experts and health leaders, like the Indigenous physicians here, are extremely important, besides speaking to Indigenous clients and Indigenous leaders, like, for example, chiefs. So I think I'll end my statement there, and I'm happy for discussion. Thanks very much.
Thank you very much, Dr. Adams. So we'll now proceed to a round of questions. We'll start with Mr. Vidal. Mr. Vidal, you have 6 minutes.
Actually, Mr. Schmale is going to take our first slot, Mr. Chair.
Very good.
Thank you very much, Chair, and thank you to our witnesses for that testimony. I think a lot of the common theme we've heard, especially from our first 2 witnesses, centered around bureaucracy and the slowdowns that can occur when a government department gets too big, too bureaucratic. As was pointed out, it costs lives in some cases. We've heard testimony in the Veterans Committee where veterans have to reapply to prove that their limbs are still missing. This seems to be a common theme. Maybe I'll start with Dr. McCocas if I could, and then maybe get Dr. LaFontaine to jump in. It seems that bureaucracy, as was pointed out in your testimony, Doctor, only moved, as you pointed out, to when you kind of hit the panic button, so to speak, and kind of shock the department into actually doing their jobs. This must be extremely frustrating for you, as I think was very clear in your testimony. How would you go about, maybe as some people have suggested, restructuring the department as a whole so it actually functions properly?
Sure. So thank you so much for your question. It's a complex question with complex solutions. I actually used to work in First Nations Inuit Health Branch as a university student. And so sometimes I would walk by the NIHB employees and staff and have a listen to the conversations that they were having with our people. Some of them are around medical transportation that was mentioned previously. And they would say, well, why can't you just walk to the health center? There's no public transportation on reserves, as people know. And so what I find is that the bureaucrats who work under the program are completely out of touch with the reality of the lived experiences of people on the reserve and the communities that they are supposed to provide. And they actually act as an extreme barrier to the provision of basic standard care. They don't have any training about Indigenous peoples, about Indigenous people's health, about our treaty promise to health and the provision of healthcare medical services and supplies. So that is a huge issue. You mentioned a second piece, which is the tremendous advocacy that physicians or health providers have to do to navigate and get items covered under that program, which as Indigenous physicians, myself and other Indigenous colleagues that work within our own people, routinely have to get people's names and supervisors and document it in the medical chart and literally say, you will cause the death of this patient, and I'm documenting this, and your name will be on the death record potentially as one of the contributing causes. And only then are items covered under this program. And it shouldn't take that level of advocacy. Most health professionals don't even know how to navigate through this system because they're not taught about it within their professional schools, whether that's medicine or pharmacy. It's only when we are forced to work within this system that we have to figure out which buttons to press to ensure that something is covered. And when we compare that to any other extended health benefits, whether that's Blue Cross or Manulife or any of the other ones that are, within this country, providers routinely say that the NIHB program is the most difficult and causes the most harm to patients when they want to access it, and also the most humiliating for patients to access it when they're actually at the provider looking to have their pharmaceutical or their medical equipment covered and having to stand there and advocate for themselves to great lengths to ensure that they actually receive proper care.
Dr. Mikokos, thank you. That was actually great because that actually answered my second question, which was how does it compare to other programs? I will get back to you in just 2 seconds. I just want Dr. LaFontaine to quickly chime in.
Yeah, thank you for that question. And just for the interpreters, if my headset's causing problems, just let me know and I'll switch it out to something different. I think when we look at bureaucracy, it's sometimes an easy target when things fall apart. I'm not saying that bureaucracies need to be big, but we do need people whose jobs are to measure metrics, follow costs, make sure that workflows get followed through, auditing, all those other things. I mean, this takes people time and effort. Otherwise, that responsibility falls on to whoever else is left within the system. We know that one of the major causes of burnout among physicians is actual administrative work. And so I'll try and temper some of that criticism of bureaucracy in my answer. I think the challenge is workflows, actually. The federal government is not a provincial or territorial medical system. And ISC has gone through an evolution where they've changed from a program that's, usually based on grant funding or other things to a more sustainable program where they're trying to design and create health systems in partnership with First Nations, Inuit, and Métis nations across the country. Along the way, revisiting those workflows, asking the question, do 3 people have to approve this? Can just one person sign off on this? Could the responsibility for signing off actually go to the physician? These are the same struggles that we actually have within our provincial and territorial medical systems. Me having to phone an administrator to get permission to, say, do a surgery at 1 a.m, could create adverse problems for a person who needs, a open fracture fixed in the middle of the night. And I think in the redesign, leaning towards understanding what the workflows are trying to get out of the system and lining that up with the needs of patients, right care, right person, right time, in a place that's as convenient to them as possible. In your last panel, there was a comment from one of the panelists that talked about sometimes we can't actually create these systems because of cost or limited resources. We know that health human resources are at a critical point right now. Trying to work through what's best for the patient and trying to line up those approvals and auditing processes to make sure that we're compliant with workflows that work in their best interest, I think is our recommendation from the CMA to explore this type of program redesign.
I think when you talk
Thank you, Mr. Schmale. So we'll now go to Mr. Hanley, who's sharing his time with Ms. Atwin. You have 6 minutes.
Thank you very much. Thanks to all 3 panelists for a really fascinating discourse. Certainly a common theme is incorporating First Nation, Indigenous leadership and patient experience into program design, but also maintaining that public accountability of running what needs to be a publicly funded institution. So I appreciate there is a balance. I think my first question is to Dr. Adams. Dr. Adams, you and I have known each other in many different roles over the years. And one question I have is when I look back to your experience with First Nation Health Authority, you were one of I think the instrumental people in helping to design the First Nation Health Authority. I think it's a really good example of incorporating First Nation leadership into program design. I wonder if you could just comment briefly on what you learned from that and how you might apply that to how we can address some of the perhaps inefficiencies that have been witnessed in talking about NIHB.
Great. So this is a subject area that I could talk about for a while. The First Nations Health Authority has been evolving for many years and now is a First Nations health organization that has close to 1,000 employees, helping about 160,000 First Nations people in BC. So a few themes. One is self-determination. It doesn't make sense for First Nations Health to be run from Vancouver or from Ottawa. Perhaps some more local workers and local knowledge could be incorporated. We understood that sometimes our workers who are meant to be helpful, not hurtful, are not well versed in our communities and community needs, and that a clerk in an office in Vancouver making health decisions that supersede that of an Indigenous physician who's on the ground, or any physician or healthcare worker on the ground, is completely inappropriate. And we had changed the way that business was practiced. As many of you know, with quality improvements, making changes just to very simple business practices, like how quickly can you get a scalpel to an operating room, requires quite a lot of cooperation and an admission by those workers in that chain that they can do better. So in BC, that was the beginning of that transformation, and we made quite rigorous commitments through First Nations leadership, but also at a tripartite level. I haven't heard, since I arrived on the call, I haven't heard mention of the responsibility of provincial services, which is the lion's share of services. They employ doctors, nurses, run hospitals and clinics. So the cooperation of the province, the federal partners, First Nations, and particularly First Nations health leaders, not just leaders. Chiefs can make some change, but health leaders like Dr. LaFontaine and Dr. McHocus absolutely need to be a part of that process and part of the rigor of making change. They hold the moral high ground in order to ask for those quality changes. Thanks.
Let Ms. Atwin continue for the 6 minutes.
Thank you so much, MP Hanley. And with my brief time, there's so much that I could say, but I just first would like to acknowledge I'm speaking on the unceded territory of the Willistoq here in New Brunswick. So I think with my limited time again, I just want to thank Dr. McCokus for your testimony today in particular. The honesty is really going to help, inform, our work moving forward. Dr. LaFontaine as well, congratulations on your election. The previous chair happened to be from New Fredericton, actually, so Dr. Ann Collins. My question is for Dr. Adams. Big fan, by the way, I have to say that. Some of the themes that have been coming up, we talk about the need for it to be Indigenous-led, absolutely. Also the need to address, systemic racism within the system, informed advocacy, all these pieces. And I know that a big piece of the Indigenous Physicians Association of Canada is looking for that capacity building. So how can provinces and territories and communities recruit and support Indigenous doctors and medical professionals to help deal with some of these issues?
Oh, that's an excellent question, and I hope that you will keep asking that question to a number of professionals. So just really quickly, absolutely getting learners ready so that they're eligible to apply to medical school. So really, that's undergraduate, even high school level programs. Admissions is another area, and then support for Indigenous learners who are in medical school, because they are quite unique. They are, like those here. They have phenomenal responsibilities within their communities as community leaders, as cultural leaders, as keepers of Indigenous knowledge, besides going to medical school. And many of them are older, many of them already have families, so they need support. They're a different kind of learner than the average medical student. Last of all, they need jobs, and wonderful that we can be working in hospitals and clinics alongside our non-Indigenous colleagues. But really, Indigenous physicians need to be able to ascend. They need to sit alongside chiefs, like as their medical officers. Indigenous people can have their own medical officers as their senior health advisors, and we need Indigenous physicians and other healthcare professionals at the highest levels to ask for accountabilities and change. Thanks.
Is there more time, Mr. Chair?
No, I'm afraid
Okay.
that's just run out the clock. Thank you, Ms. Atwin. Alors, on va aller à...
So we'll now go to Ms. Gill and Mr. Morris. Ms. Gill, you have 6 minutes. Thank you, Mr. Chairman, and I'd like to thank all of the witnesses once again, thank you for testimony. I think it's interesting to hear what's happening on the front lines. You really see what the reality is, and in a tangible way, and the difficulties, of course, as well. I would like to hear you make some recommendations and enlighten us in terms of all of the difficulties that you run up against. I know that there's a lot of bureaucracy and paperwork. I know in Labrador that's often an issue in this area. It's very difficult for the people to trying to get care in this region. So if you could talk to us more about that, I'd like to hear from all three of you. Thank you.
Ten, would you get us going on that one?
Sure. I think it's a really good question. What do you recommend to actually fix some of these problems? I'll keep my comments focused. The first is that you need people to provide the services. So just in the same way as we need an integrated pan-Canadian health human resources plan, I do think we have to look at that. And just like Dr. Adams was talking about and Dr. McCokus has mentioned, it is a struggle to recruit Indigenous physicians into Indigenous communities to provide care to Indigenous patients, and that's extremely important. The second part is not just comparing costs internally against the NHB program, but also looking at relative care between provincial and federal systems. I think the goal of the CMA is to advocate for equitable care. That means when you come through a door, whether you're Indigenous or non-Indigenous, you receive the same care and the same sort of access, the same type of timely service. And I think finally, as we look towards making changes, there's things that we can learn from Indigenous health systems, and there's things we can learn from Medicare. We're introducing pharmacare and dental care, hopefully, into our national Medicare regime. There are decades of experience on how that has worked and not worked within Indigenous communities that we can learn from. And we have decades of experience of how to fix other problems that Indigenous communities are going through within Medicare. So thank you.
Thank you, Dr. LaFontaine. Dr. McCocas?
Thank you so much for your question. I think it's really important when we look at the provision of medical care and medicine that we're actually following medical practices that are, keeping up with the current times. If we look at the, processes that are existing within the NIHB system, there's flow charts of, multiple steps that patients have to jump through. And the example that I can give most clearly is rheumatoid arthritis. People should not end up in wheelchairs with amputations and disabled because they're not provided the proper medication that exists today in the form of biologic and immunological agents with things like Humira. Instead, those patients have to jump through older medications and their joints are completely destroyed by that time and end up dying and disabled. And we should not be seeing that in a country like Canada. So one is we actually need to follow medical advice and recommendations that keep up with the fast pace of medicine. Two, I think if we look at our original agreement within the medicine chest, which is a symbol of healthcare that would evolve into the future, it was all encompassing. So it included medicine as it would evolve, the pharmaceutical drugs that would come, medical equipment and supplies that would come. And again, there are very rigid parameters as to how people can access this. If we look at diabetes, foot ulcers, the basic principles of wound care, which is having, wound vacs or having patients wear air casts to offload pressure, none of those are provided. And then we look and see the rates of amputations for Indigenous peoples is the highest in this country. So we actually need to provide care that reflects the needs of the state of health of Indigenous peoples, which is the worst of any group across this country. And that is not something that our ancestors agreed to when we agreed to share this country in peace and friendship, is to ultimately, 150 years later, be in a worse condition than when our relatives arrived on the shores of this country.
Thank you, Doctor. Dr. Adams?
Yes, and I hope we have talked about UNDRIP and decisions being made about Indigenous health without Indigenous people at the table. That time should be over for a couple of reasons. Indigenous decision making is more than making a system faster so that more Indigenous people can have more drugs faster. That is not the point. And so with Indigenous consultation, we can decide which parts of the system need to be addressed. We need to look upstream, not up and downstream, of course, as well. We take the criticism at First Nations and Inuit Health Branch. We need to stop people from falling off the bridge rather than trying to help them once they're in the water. And upstream investments in our peoples means spending money on children, on prevention, in the social determinants of health. If FNIB cures your cancer, but we return you to homelessness, unemployment, and poverty, have we really done our jobs? So we really need to be holistic, and Indigenous people are very holistic in their approach. And I think they're very clear on what improvements need to be made. And if they're at the table, we simply have to talk to them. If they're at the table, they will point in many directions where we can invest time and make improvements. Thanks.
Thank you. I'm afraid, Mr. Morris, we've run out of time, but perhaps a quick second round, you might get in there. We now go to Ms. Idlaut. Ms.
Thank you. First of all, I wish to thank you three for coming to give us this presentation. I know that when it comes to First Nations and Métis and Inuit, you may be limited with some of the Inuit and other Aboriginal groups. The one that I can relate to is Dr. Makokis. As you are in direct delivery and you're a care provider, I admire that very much. I wish to ask you this now, Dr. Makokis. In what ways do shortfalls in NIHB funding for both traditional indigenous medical systems and Western clinical services, in what ways do they impact indigenous people?
Edloat. I think this is a very long answer. When we look at the state of Indigenous people's health in this country, it's directly proportional to the systemic dismantling that has occurred through federal policies and laws. So our people had our own health systems and method of health and healing and medicines that helped to keep our people strong, well, and healthy, well into, the ages that we're currently living with all of the advents of Western medicine technology and pharmaceutical drugs. We know that the federal government from 1984 to 1951 banned ceremonies including potlatches, indigenous medicines, and ways of being that form the fabric of our medical system. And we're seeing the direct result of that in the high rates of chronic disease, infectious disease, and suicide mental health issues that Dr. Adams mentioned. For there to be a dramatic transformation in all of these health statistics, we actually need to systematically rebuild the Indigenous health systems. That starts with funding Indigenous healers, elders, medicine people, and also young people that can train in their footsteps. We're at the verge of the possible extinction of our knowledge as it relates to Indigenous medicines when it comes to how to keep our people healthy and well. And we know that when we look at research from the Aboriginal Healing Foundation, that Indigenous peoples routinely rated our own medicines and access to our healers and medicine people higher than, and more important than accessing Western medicine and physicians and Western allied health professionals. When we look at the non-insured health program, as Dr. Adams mentioned, yes, travel to see elders and traditional medicine people is covered, but the compensation to them as a practitioner within our own health system that's been decimated by Canadian law is not covered. So that's left up to the patient to cover themselves. And we stopped paying for physician services back when the Canada Health Act was implemented back in the 1980s. And funding was provided by the federal government to provinces and territories to help pay for physician services. So we also have to pay for Indigenous health services as practiced by our own people, for our own people. And we know that it works the best. We've had Western medicine for the past, I don't know how many decades, and we haven't seen a transformation in Indigenous mental health, physical health, or spiritual health. And what we actually need is our own medicine supported in a systematic way that is supported, that has longevity, that our people can access, and that's what they're looking for. And we haven't seen any funding, we haven't seen any resources put towards this. And Indigenous physicians that work with our own elders and healers would be a tremendous resource to help be able to guide this process, working in conjunction with our own people and our own leaders within our own communities. And unfortunately, there are very few Indigenous physicians with that background, but there are some that would be willing to provide this help and guidance.
Thank you. I'll make this short, my last question. Can you give an example of a transfer of health services to Indigenous nations? Would you provide an example of what you've seen in transferring to Indigenous people?
Nations Health Authority, which is constantly referred to as, the example across the country of what should be done. I know that in the province of Alberta, for example, which has Treaty 6, 7, and 8, that some nations within Treaty 8, like the Big Stone Cree Nation, have taken over their NIHB program. I have patients that access that because I see them as a frontline provider. And what I found that, and what other Indigenous physicians have found that work with that particular program, is it's actually even more difficult to get the pharmaceuticals, drugs covered, the medications, the equipment and supplies. And what I observe happening is that the restrictions that were under NIHB are actually exacerbated. And I'm not sure if in this transfer of funds to the nations and communities themselves, if the funding is actually further restricted so that communities and nations are then actually administering their own poverty with funds that are given and transferred from, federal programs and things like that.
Thank you very much, Ms. Seidlout. Colleagues, we have a little bit of time left. I'm going to make a proposal that we start the second round with 3 minutes to each of the first two speakers, and then for the third and fourth, one question. So that way we can probably finish on time. So I'm going to start with the Conservatives. I'm not exactly sure who would be the speaker, but you would have 3 minutes.
Okay, thank you, Chair. And just to pick up from Dr. Mikokis from our last conversation, I'll go to Dr. LaFontaine. When you're talking about the costs, it seems that, as was mentioned, instead of having 3 people decide you have to sign off on something before you actually see some movement, there could be some real efficiencies, and then change those dollars in from funding bureaucrats to actually going into the care of individuals.
I do agree with that statement. I think in exploring the workflows, we do have to be careful that we don't assume that those costs can be transferred to patients. But I do believe that, yeah, your comment is correct.
Dr. Mikokis?
Sorry, can you just repeat your question?
About just talking about costs, where we have excess, in some cases, excess bureaucracy, where if we improve as Dr. LaFontaine said, the workflow and ensuring that things are getting done in a timely and efficient manner, we might be able to hopefully move some of those dollars into actually funding the care that's needed.
Yeah, so I think that if you look at Onion Lake Cree Nation, what they're looking at doing is having treaty-based funding given directly to the nation to administer and look after their own health agreements and look after the priorities of their own nation as it comes to health. As we know, if we look at the bureaucracy of Indigenous Services Canada, the money that's provided for Indigenous people is actually siphoned off by this large bureaucracy, and a very small amount actually ends up to the people who require it and need it the most. So I do think and agree that, yes, the bureaucracy does take a lot of this money when it's actually required by Indigenous people to, again, have the worst health comes out of this country. And by looking at nations like Onion Lake Cree Nation, who are leading in this area, that would be an example to learn from.
So, Dr. Mikokis, just out of curiosity, those stories that you the painful stories that you were able to present here to committee, when you had to basically, as I mentioned before, hit the panic button before you saw any movement, were you actually speaking to somebody on the other line from the department that had medical experience, or was it just somebody who happened to pick up the phone that day?
So the people who are trained in NIHB to answer the phone are non-medical professionals. Sometimes they do hire medical professionals, as I mentioned, with the national pharmacists, and there are regulated health professionals that are part of that program, but largely are just, regular people without a medical background that follow the flow charts and decision-making processes given to them by Health Canada under NIHB. And I have to advocate to these non-health health professionals about somebody's personal health history and try to get across to them my medical decision-making process when they don't have any background or understanding about that.
Do you have one more, Chair? You seem to be waving your arms.
Thank you very much.
Okay.
Thank you very much, Mr. Schmale. So we'll now go to the Liberal, whom I believe is going to be Mr. Vance. Mr. Badaway, I beg your pardon.
Thank you. Thank you, Chair Mark. Thank you, Mr. Chairman. I have one question. I'll be splitting my time with Ms. Atwin, but I do have one question. I appreciate the time split with me. With respect to Dr. Makokas's comments, and I'm very much interested, being the PS for Indigenous Services Canada, to work with you, Doctor, as well as Dr. LaFontaine and Dr. Adams, to establish a direction for community health, a more formalized community health plan. So I guess to all three, is there or has there been established, I'll use the words, a strategic plan with respect to overall community health within Indigenous communities, on reserve in rural areas, smaller communities, and other on reserve communities as well? Has there been a strategic plan that's been consistent, or is a desire by the three of you to be implemented on reserve?
So in the interest of time, I'll direct that first to Dr. Adams, if you want to comment, then Dr. Makokas, and then Dr. LaFontaine.
Sure. BC has a tripartite First Nations health plan. The first document was quite slim. I think under 10 pages. The next plan, after they finished their initial mandate, was much longer. I think First Nations, Inuit, and Métis have actually described well where they would like to invest and where their priorities are, and I think it would be very welcome to just to have them lead those kinds of directions and investment. It doesn't make sense to enact care that hasn't been asked for and from a distant location. It really needs to involve local peoples. Thanks.
Thank you, Dr. Makokas.
So I think one of the issues that we routinely see as Indigenous physicians who work in the community, in which there are very few of us that do that, is that we are left out of the decision-making process. And we're actually not asked about our routine experiences that we have as we interface with these programs. When I talk with other allied health professionals like pharmacists, optometrists, opticians, nurses, they have the same experiences when it comes to these programs. And I think that's one of the biggest challenges, is we actually need to speak with, dialogue, and have conversations with the users of these programs, who then can articulate these types of experiences that are real world and real time with real people of what they routinely go through on a regular basis. I didn't talk about, I know that in the previous panel, the importance of having chaperones. Chaperones can be life-saving for individuals who routinely face systemic racism within the healthcare system, because they're going to be the ones that advocate and see that in real time. And we know what happened with Joyce Echaquan, as well as many others within the healthcare system of Canada, where people are dying because of systemic racism. So we actually need to have conversations with the users of the program, with the bureaucrats who are often forced to sign non-disclosure agreements that they can't talk about the injustices that they see within the program. And you can talk with some of the Indigenous Services Canada nurses who I interface with routinely on a regular basis, who see the injustices but are unable to bring them to the attention of media because of these NDAs that they're forced to disclose. And under their own regulatory profession and advocacy as nurses, they're not able to bring forward. So I think there's many issues. This is just the tip of the iceberg. And I think this conversation needs to be expanded to include more people.
And let's do that. Mr. LaFontaine?
Yeah, thank you for the question. I was part of an alliance called the Indigenous Health Alliance from 2013 to 2017. It had more than 150 First Nations across 3 provinces who participated in it. There was Anishinaabe, Aski Nation, Northern Ontario, Manitoba, Keewatin, Alkamakanok in Northern Manitoba, and the Federation of Sovereign Indigenous Nations. We had the support of the AFN. We were meeting with ministers. And at the time, I gained a real insight into the question that you just asked. If you use the example of cooking, what I think we often ask communities to do is walk into a kitchen with foreign ingredients and cook what they want. And I think that that's how it is with healthcare for many people who aren't in healthcare or have been through a past patient experience. You don't really know what you don't know, and you don't know how the pieces fit together. The most valuable thing that we did with that alliance, and something that we try and do here at the CMA, is give people examples of what to cook. Teach them what the different ingredients are, how they mix together. I think if you're looking at scaling, different approaches, it's giving communities, First Nations, Inuit, and Métis communities across the country, the ability to pick and choose what they want to eat, but then understand about nutrition, understand about cooking, understand about the ingredients, etc. The question is not if people can cook, it's can they cook with what we give them? And I think we have to change our orientation from asking if communities have capacity to assuming that they have capacity, but do they have the supports that they need to make better decisions?
Thank you very much, Mr. Badaway. Interesting analogy, Dr. Lafontaine. Madame Gill.
Ms. Gill, are you going to take the question or give it to Mr. Morris?
So, Madame Gill.
Ms. Gill, you can ask one question or give it to Mr. Morris. I'm sorry, I thought you were speaking to him directly. Of course, I'm going to give my time to Mr. Morris. Thank you.
Thank you, Mr. Morris. You have time for one quick question.
Merci encore.
Thanks again, Ms. Gill.
Witnesses who joined us this afternoon. I was particularly struck by the comments you shared, Dr. Makokis, including the limitations and inadequacies of this very committee structure and the fact that I can only speak with you in English. I wanted to just offer, if there's anything you haven't had a chance to already share with this committee, to have time to share that now.
Sure. Thank you so much for that opportunity. If I think of my own family's experience in interfacing within not only the Canadian health system, but with NIHB, there are tremendous amount of years of loss of life. And when I reflect on what our relationship is supposed to be as a treaty descendant and Treaty 6, that's not what it is supposed to be. And I think in our lifetime, we want to see the transformation for the betterment of our children, of our grandchildren and great-grandchildren to be able to live and thrive and be the best possible human beings, that we are meant to be here together. It shouldn't take the tremendous amount of advocacy and work to obtain the basic, most foundational provisions of providing care. And what I would challenge some of the MPs, because what we often hear as Indigenous physicians from Indigenous Services Canada is that this program is comparable to any other federal program, including the ones that MPs have access to. I would challenge you to switch your program from your extended benefits that you currently have to the one that people that are Inuit and First Nations are forced to use. And you can see how quickly the things that you routinely take for granted for your health, for your family's health, are taken away and removed. And when you go and access care, the basic humanity that we strive to provide all people, as is in the mission of Health Canada to improve the health of all people within this country, changes suddenly. I think that when we look at health transformation from an Indigenous perspective, we need to rebuild the Indigenous health system. We've seen over the past 2 years with COVID, what happens when there's a threat to a health system, how quickly it crumbles, how quickly many of the provincial and territorial health systems were on the verge of collapse. And that's only after 2 years, let alone 1885 to 1951, when we couldn't even access our own health system because we couldn't leave the reserve due to the past system, for example. And so when we think of things in that perspective, there's a lot of work that needs to be done to rebuild the Indigenous health system and support Indigenous health healers, medicine people, and elders who, when we do this, will actually start to see a change in the morbidity and mortality that we have become so used to when we talk about Indigenous people and Indigenous people's health and the deficits around these. So in my lifetime, that is something that I would like to see as someone who's 40 years old, who's one of, the non-fluent Cree speakers in our community. And in the next 20 years, there's a potential loss of the Cree language that if that happens, what we're going to see is worse health outcomes than we already have. So I know Dr. Adams talked about upstream health determinants. Language is an important part of that. Upstream health determinants, traditions and culture is an important part of that. And that's what we need to focus our attention to. And that's really what reconciliation is.
Thank you, Doctor. Ms. Sidlaut, would you like to finish with a question?
Yes, very much. One question. I have a question to Dr. Makokis. I'd like to ask you, as a physician, do you have the ability to prescribe and refer patients to traditional healers? If you do, and how does that work?
Thank you so much for your question. So again, MP Idlout, I have spent a significant amount of time with our elders and medicine people, learning our own medicines and traditional medicine practice alongside of my Western medical journey. So during medical school, during breaks, I would go home and spend the summers with elders. During weekends, I would go home and learn from them. There are very few Indigenous physicians who do this. There are a handful of us that do that. And as part of our regular practice, we routinely refer to healers and medicine people and elders within our own community because we know the network that exists there and they trust us. This is an important part of our health system. And unfortunately, this is not compensated. So what I do as a physician what I've done in the past working fee for service is I would go and do a home visit with an elder and the patient, and I would bill the provincial health system a home visit fee, and I would split that fee myself 50-50 so that the elder or traditional medicine person is compensated equitably to what I would be compensated. And I did that myself. Now, there needs to be, and this is not something that's sustainable. Like most health professionals, most doctors, most nurses would not donate 50% of their salary to someone. And that's really what we need to talk about is how we are going to adequately compensate our medicine people and elders that are identified by our own people that we use in the community. And so that is a very important part of our health system. So yes, I do that. It's not compensated. It needs to be compensated. There needs to be more of that. If we look at the Dene College in the Navajo Nation, they have a training system for Indigenous traditional medicine people and for Navajo students to go and learn that by their own elders within their communities. We need to have processes for doing that in this country, whether that's Indigenous medical students, Indigenous medical schools, where we're training alongside our elders and traditional medicine people and providing care in a culturally safe, appropriate way that is just as equal and valid as Western medicine.
Thank you very much. On behalf of all the committee, I would like to thank our witnesses today, Dr. Lafontaine, Dr. Adams, Dr. Makokis. Thank you for your testimony. Thank you for your candor. I think you've provided a very valuable input to this committee's work, and we very much appreciate it. So thank you. Do I see somebody's?
Yes, Mr. Chair, it's Mr. Badaway would like the floor.
Just quickly,
Please,
Mr. Chair.
Badaway, go ahead.
Thank you, Mr. Chairman. If I may, to the witnesses, to all three doctors, my office will be reaching out to you further this discussion with respect to a lot of what we talked about today, just to get some more time and discuss some of the things that we've talked about at today's meeting. So, and I want to thank you for your time today. Thank you, Mr. Chairman.
Thank you. And with that, this meeting is adjourned. Thank you.
Thank you.